Hi, my name is Dr. Brian Gruber and I'm the founder of Integrated Orthopedics. So today specifically we're going to talk about the biceps tendon at the elbow. People will call the office and say that they injured their biceps tendon, and there are really two areas to injure it. Number one, you can injure it at the shoulder, and number two, you can injure it at the elbow, and the treatment's much different. We're going to today in the focus of this piece, we'll talk about biceps tendon injury specifically around the elbow region. The biceps tendon injury is usually a male-dominated injury, and that's just based on the case reports and what we see clinically. Oftentimes what happens is that the biceps muscle is firing and pulling the forearm up, and the force on the arm is pushing back, and what happens is the biceps tendon muscle or tendon gives and it snaps. So the anatomy is it starts out as the muscle, so it starts out as the biceps muscle, then it turns into a tendon, and then it hooks onto a bone in the forearm. So it allows you not only to flex your elbow, but most importantly allows you to supinate, and that means take palm up. So what people see, it's not exactly a loss of flexion that we're concerned about, it's really the supination. So somebody that has a biceps tendon injury would have a very hard time doing a screwdriver, for example. So that's really the main indication that we use to fix that, is the significant loss of supination. So oftentimes the patients will come in and they'll say that they felt a pop in their arm, and what they might see is significant bruising of the arm. They would have oftentimes a deformity. We call that a Popeye deformity. So when you compare the muscle side to side and have them sort of make a muscle, there's abnormality, and they look asymmetric. There's a test from a physical exam technique called the hook test, where you typically can feel someone's biceps tendon, and when somebody tears it, you can lose the tendon and you don't feel it. So what happens really is the tendon snaps off of the arm bone, and it sort of goes up into this region north. So that's why you get the deformity, because the length tension relationship is gone. Other ways to diagnose this, so usually we do like to have some imaging. This can be diagnosed either via ultrasound, or we'll do an MRI. The distal biceps tendon is one that a procedure that is typically treated surgically almost all the time. There are obviously cases, say somebody is, in a nursing facility, and they're 85, and it was really a fluke accident, and nobody wants mom or dad to undergo surgery. That's very reasonable. However, that's usually not the typical patient population this happens, and usually it's the younger laborer that has this type of injury. What we like to do is get to it within a couple weeks. And that's kind of basic orthopedics from a tendon injury standpoint, where the tendon, once it tears, it can kind of shorten up and retract, and it can become more difficult to fix. So if somebody comes in 6 weeks later or 8 weeks later, they can be more challenging to fix. So that's why we'd like to get to these injuries early. So the surgical treatments, basically it's a small incision on the forearm, and we do this under x-ray to make sure that we're on the right part of the bone. It's called the radial tuberosity. So what we'll do is we'll find the tendon, and then bring the tendon back down to the bone, and fix the tendon back to the bone with various techniques. Primary technique would be where you're able to take the tendon back down to the bone, and there's essentially a tension-free repair. There are certain situations with, for example, if somebody comes in and say it was misdiagnosed, or they didn't see a doctor, or for various other reasons, they show up and maybe they're a couple months out from an injury. That situation, we're pretty confident that we're probably not going to be able to primarily get the tendon back to the bone, because like we talked about before, it shortens up. So in that situation, we do a tissue augmentation technique, and what that really allows us to do is add some length to the tendon. So say we need to add an inch to the tendon length to be able to take it down to the bone. What we'll do is we'll take cadaver tissue, and we will weave it into the biceps tendon, and that gives us the appropriate amount of length to then go down to the bone. So the typical surgery time for a primary biceps tendon repair can be as short as 30-35 minutes. And that can go, if you're doing an augmentation procedure, it can go up to an hour and a half or so. This is not an arthroscopic procedure. By definition, arthroscopic means in the joint. So this is a problem that's actually outside the joint. So it's not in the elbow joint itself. It's outside the joint, so it's done with a small open incision. Some of the common things that we see, probably the most common, if you want to call it a complication, what we see is people have numbness on this part of the forearm. And why that is there's a nerve it's called the lateral antebrachial cutaneous, which is just a long name for a nerve that runs right by the forearm here. When we retract in the wound, what happens is we put pressure on that nerve, and people almost always get some numbness that does resolve. But we let all of our patients know that because it's not a motor, so they're able to move their fingers and all, but it's just a sensation thing, and that does come back. The typical postoperative period, initially we have patients in a splint, so they're at 90 degrees, which there's very little tension on the repair. So the further we extend the elbow, so full extension has the most tension on the repair and full flexion has the least tension. So we kind of go in the middle at 90 degrees, which is relatively tension free for the most part. And then we see patients back at about a week, and we put them in a hinge brace. It's kind of like one of the RoboCop braces where it has a dial on it, and over time, what we do is we start, in increments, typically 10 to 15 degrees a week, we start letting the patients go to full extension. That is coupled with physical therapy, and there's a lot that the therapists do to sort of, if you want to call it, minimize collateral damage, keep the forearm strength with different techniques, with the hand. Obviously the same way with the shoulder. We worked on the elbow biceps region, but you don't want the shoulder to get tight, you don't want the wrist to get tight. So there are different things that the therapist will do, that our therapist will do to sort of make sure that the rest of the arm is functioning appropriately. The success rate for distal biceps is excellent. Patients, do really well. Typically, you're dealing with, good, younger patients. Their tissue quality is very good. And really, what we have to do is really pump the brakes on folks because they're feeling pretty good pretty quick, and you don't want to stress the repair too early for fear that you could re-rupture hypothetically. The total recovery time for something like this, specifically for the labor, is somewhere between 3 to 4 months before you're really getting back lifting heavier type objects. It's important if you see, if you hear a pop in your arm, if you see deformity of your biceps tendon or biceps muscle, that's something that you want to get evaluated, sooner than later. So it's not something that you want to sit on for 6 or 8 weeks because it makes the surgery more challenging for sure, and a little, if you want to say, less predictable. Maybe a little less predictable than being able to do a primary repair.